Welcome back. Today we're going to conclude the study of the urinary system by focusing down on the physiology of the kidney and primarily really of just the nephron. We're not going to look at the gross anatomy anymore. We're just going to look at the microscopic physiology of the functioning unit of the kidney, which is the nephron. Now, we tend to think of this organ in general terms as an excretory organ, but it's really one that's involved primarily with homeostasis, the maintenance of a stable internal milieu. And the excretion is really a byproduct of that maintenance of homeostasis. This is a point where we want to take a little bit of an aside and just look at the process of osmosis and what it means. We've mentioned it a few times before. I want to mention it one more time, only this time with details. Let's look at the first slide. Osmosis is defined as the passage of water molecules across a semi-permeable membrane from a lower to a higher concentration of water molecules. If you look down here, we have a schematic representation of water, and it is separated from the other side by a semi-permeable membrane, a membrane which will allow the passage of certain size molecules. If we consider this a closed container, and on this side we have water and dissolved sodium, potassium, chloride, and glucose. All these molecules, which are in solution, serve to raise the concentration. Now, we often look at the concentration of the dissolved particles, so many milliequivalents of sodium, chloride, etc. But in reality, the physical chemistry of this is it really decreases the concentration of water on that side, because a certain amount of that water has been displaced by these other molecules. Whether you look at it as concentrated solutes, dissolved particles, or the concentration of water is not important. The importance is we're going to move from the side of higher concentration to lower concentration of water. What happens in this case, there is a pressure exerted for the water to come across the semi-permeable membrane and raise the concentration of water, thereby diluting the other particles. It'll exert enough pressure so that if we have a measuring tube at the top of this container, we might see the water rise in that tube so many centimeters of water or so many millimeters of mercury. It's an actual physical force pushing across. You came across this in the nervous system when we talked about a subdural hematoma. That blood clot, after many months, broke down its particles and caused a lot of dissolved solution in a liquid medium, creating osmotic pressure to suck fluid into it and then expand it with pressure, creating a problem for the brain. We're going to see that a lot here because osmosis plays a major part in the physiology of the kidneys. Let's go back to our first schematic diagram and remember the nephron. Just by way of review, we have the glomerulus, the little ball, with its intruding arteriole right here into what's called the capsule of Bowman, and then the glomerular filtrate, which comes across, exits in the proximal convoluted tubule. Here we go again with doctors just describing something. They didn't have to know what it did to give it a name. It's proximal, which means near, it's convoluted, which is twisted, and it's a tubule, it's a small tube. This then dips down into a descending loop, what is called the thin loop, and it returns through the ascending loop of Henle. And now we have a distal or far away convoluted tubule, and this then goes into a collecting system where some changes take place, but not many. I said in the last lecture that nothing much happened here. We do get some changes. Let's go back now and look at one more structure that I'm going to mention later on. If you look at this other representation, this ascending loop of Henle, just where it meets the distal convoluted tubule, has a spot right here called the juxtaglomerular apparatus. Juxta means next to. It's next to the glomerulus, but it's not touching it. And this apparatus looks something like this. It's got an area called the macula densa, which is part of the tubule. And then it's got this little apparatus, and this is next to an arteriole, one of the afferent arterioles. So if you look back here, you can see them coming very near each other, only a couple of cells apart, and it is involved in the release of certain hormones, which I'm going to talk about later. It's an anatomical part that I haven't discussed yet. If we look at the glomerulus itself, the first thing we want to talk about is glomerular filtration. There are three things that happen in this system. First, fluid is pushed across those arterial capillaries as a filtrate, meaning whatever goes across into that Bowman's capsule has been filtered to some extent. That's glomerular filtration. What really happens is that almost everything gets pushed across. There's just a few things that don't. The body starts off with a clean slate and dumps out everything that may or may not be garbage. Then we have tubular reabsorption. In the rest of the loop that we see, we start going through the tubule very slowly and reabsorbing what we need. That's tubular reabsorption. That's the second process. Finally, we have a third process called tubular secretion, and that's an active spitting out into the tubules of things we no longer want, so that these patients can get, again, rid of what they don't need and reabsorb what they want. Let's go back now and look at the the glomerulus and its arterioles. There are pressures involved here that are critical. This is called glomerular filtration pressure. And this pressure is a simple series, it's an equation that's just a simple series of addition and subtraction. Generally speaking, no matter what the blood pressure is in the rest of the body, as long as it's within normal limits, let's say a systolic pressure of between 90 and 130, the arterial pressure on the afferent side enters the glomerulus, and in relationship to the exit size and other factors, it generally has a pressure of about 55 millimeters of mercury, or about half of what it has in the rest of your body. It's enough to give it a good head of steam. Now that would be the net glomerular filtration pressure if it weren't for other pressures counterbalancing that. If we look back here again, there's something called capsular hydrostatic pressure. That's the pressure exerted by the filtrate that's already in here. In a closed space, this capsule has some elasticity, but not much. And it exerts a back pressure, the capsular hydrostatic pressure, which means water standing still, that is going against the GBHD pressure, and that represents about 15 millimeters of mercury. Not very high, but we have to subtract that. And then finally, we have something called blood colloid osmotic pressure, or BCOP, and that's the pressure we just talked about. You have osmotic particles in the blood on the inside of that capillary wall. There's albumin, which is a very important component. There's lots of sugar. There's osmotic particles that are tending to suck the filtrate back in with a real physical head of pressure. And that amounts to 30 millimeters of mercury, actually twice as much as the hydrostatic pressure. So in our formula down here, to find what the net filtration pressure is, we have to subtract the 15 and the 30, and we get about 10 millimeters of net pressure. This net pressure doesn't vary all that much. You can have fluctuations in blood pressure over a reasonable range, and you don't get much change in the net filtration pressure. However, when you get serious drops in the incoming pressure, remember, you've only got a head of steam of 45 millimeters. When people are in shock from bleeding or dehydration and they markedly reduce their pressure, the arterial flow shuts off. It may not just shut down, it may, in extreme circumstances, shut off completely, and the kidney stops getting blood flow. This is an overreaction. This is where our system got too finely tuned and where other organs took over. The brain, the heart, the muscles decided to shut off the kidney during the emergency situation to preserve the important stress organs to get through the emergency. And the kidney can handle this for a period of time, many hours, in fact, depending on how severe the shock is. So that's net filtration pressure. That's the head of pressure that's pushing the filtration across the afferent arteriole, the exit here into Bowman's capsule, and tending to send stuff down the tubules. Again, just a reminder, if we look at a less schematic and more accurate drawing, remember that in those arterioles we have different size filters. We start with the endothelial fenestration, the pores, and then we have this basement membrane which prevents different size, a smaller size, and then finally the slit membrane between the pedicels, all tending to filter out different particles. We don't want the big proteins of albumin to be put out in the urine. We don't want blood cells to go out there. We don't want complex proteins to go out. We do let everything else go out because those we're going to get back. Control of blood pressure. If we increase blood pressure, we're going to get more flow beyond a certain point, and we'll have an increase in net filtration. But this filtration is also an enormous volume. It's an unthinkable volume if we didn't have the mechanisms to control it. First of all, the two kidneys together get 20% of the total blood flow of the body. Remember, that's what the brain got. So between brain and kidneys, we're getting 40% while you're just sitting at your desk. Now, proportionally, that's far more than the brain gets because the kidneys are only a fraction, maybe a quarter of the weight of the brain. So they're getting 4 times the flow per unit of tissue. We actually filter across that membrane somewhere in the neighborhood of 200 liters or 200 quarts a day. We reabsorb 99% of that. So we're going to only have a urine output of about a quart, more or less, depending on your level of hydration and activity. So we're going to filter 200 times of what the amount we're actually going to let go of. Now, we can get pressure gradients also managed in this organ, going back. Here's the afferent arteriole, here's the smaller efferent arteriole. In the normal quiescent state, we're sitting there with both sets of arterioles relaxed. Their smooth muscle is relaxed, and the head of pressure comes purely from the discrepancy in size. If we release a certain amount of sympathetic stimulation, if our blood pressure is too low and we want to get the blood pressure up again, a moderate amount of sympathetic stimulation will equally constrict both sides of the afferent and efferent arterioles, not changing the net pressure much at all. But in severe situations, we're going to shut down that filtration completely. Now, there are several components that are filtered through there. We have glucose is going to go right across this membrane and out into the filtrate. Amino acids, small proteins. We have waste molecules like urea. Remember, the liver took the waste product of ammonia, which is quite toxic, but not easily dissolved, and it converts it to urea, which is less toxic and easily dissolved, so that goes out. We have sodium, chloride, potassium, bicarbonate, hydrogen, all the ions that we're now going to juggle around and decide what we need and what we don't need. Most of the filtered substances need to be reabsorbed, except the urea and the toxins, and in some cases, the hydrogen ions. The regulation of glomerular filtration is very, very fine, obviously very, very important, and therefore we have 3 different mechanisms, which has 5 different control systems, and they're rather important because they come into play much of the time. Let's look at the next slide. This is the regulation of glomerular filtration. I don't usually like to read from a table, but having this in front of you while I'm talking may make it a lot clearer. We have 3 basic divisions: renal autoregulation, we have neural regulation, and we have hormonal regulation. So the kidney's autoregulation is the one that's working most of the time. Again, while I'm sitting here at the desk, that's what's going to be the prime regulator of my renal filtration. There's something called myogenic mechanism. When I have increased stretching of the smooth muscle fibers in my afferent arteriole. If my pressure goes up even a little bit, then the vessels are going to dilate. And remember, when muscles are stretched, they tend to contract as a reaction. Even the slightest stretching of the afferent arteriole beyond the usual elastic blood pressure pumping, when the pressure goes up, it's going to make the muscles constrict. That's the major stimulus and the reaction. The smooth muscle is going to contract, narrow the lumen of the afferent arteriole, and that effect on GFR, glomerular filtration rate, is going to be to decrease it, because we're going to lower the pressure head. We're therefore going to lower the rate, the amount of fluid that goes across. Remember now, in a single day, in a single half hour, you're going to filter, you do about 120 cc's a minute. You're going to filter in 30 minutes your entire fluid volume of your body. So this is a very critical mechanism to get this back. Otherwise, you'd be a prune and turn to dust and blow away before the end of the day. The next autoregulation is called tubuloglomerular feedback. This occurs when you have very rapid delivery of sodium and chloride to the macula densa due to high systemic pressure. Remember when we looked at the juxtaglomerular apparatus, we have this apparatus right here, and we're feeding material across to this sensing cell, the macula densa. So if in this case we have fed too much sodium and chloride, it has chemoreceptors that tell that's happening. A more complicated feedback loop occurs that we haven't even talked about yet. There is a gas, the release of which tends to cause relaxation of smooth muscle. It's called nitric oxide. There is nitric oxide in the juxtaglomerular apparatus, and it causes, if it is decreased, it causes constriction of the afferent arterioles, just like the stretch reflex. So we have two places of regulation that decrease the GFR. We want to get the amount filtered decreased in those situations. Next, we have neural regulation, and that's pretty straightforward. The neural regulation is involved with increased level of activity of the sympathetic nerves, which will release across the synapse norepinephrine, and also go to the adrenal gland and release norepinephrine in the adrenal medulla. And this will cause constriction of the afferent arterioles through some receptors, and this releases as well another drug we haven't heard of before called renin. And I'm going to tell you about renin in a minute. That, again, net effect, decreased GFR. All these mechanisms in stress are decreasing the GFR because we want to, in most cases, keep our blood volume intact. Finally, we have hormonal regulation and another new drug called angiotensin II. Angiotensin is a very potent vasoconstrictor. It has a precursor called angiotensin I, which comes from another drug called angiotensinogen. It generates angiotensin I. The renin from the juxtaglomerular apparatus stimulates the release of this chemical, and there is a enzyme called ACE, and the ACE converts 1 into 2, and angiotensin 2, is the active ingredient. When we have a decreased blood volume or blood pressure, it stimulates the production of angiotensin 2, constricting both sides of the loops in the arteriole, and again will decrease GFR. Now there's all of these, as you can see, have decreased the GFR. There's one other sensor, which really is bizarre. It's so far away in the body. It's in the wall of the left atrium. A release factor in the wall of the left atrium. It has the name ANP, atrial natriuretic. NATRI is the Latin prefix for sodium. That's why sodium has Na for its symbol. This is natriuretic peptide, so it's a small chain of amino acids. And when you stretch the atria of the heart, you stimulate the secretion of ANP. ANP circulates down to the kidney. That's the target organ. It relaxes something called mesangial cells. Those were the ones that are located back here inside this part of the glomerulus. And the mesangial cells, named because meso, it means the middle, angio means blood vessel. The mesangial cells in the glomerulus relax, increase the capillary surface, which is available for filtration, and we can filter more of the GFR across the membranes. Now, there are more. And the next one we need to talk about is aldosterone, or aldosterone. It's pronounced both ways. The adrenal cortex, if you remember, released a hormone called aldosterone. It is stimulated by angiotensin II. So when the angiotensin II goes up, there's a feedback loop that tells the adrenal cortex to release the aldosterone, which retains sodium, excretes potassium in exchange, and causes water to come back to help increase the blood volume. Now, when that happens, it's an osmotic effect. You're bringing sodium back, and we have something called obligatory osmosis. There's an osmotic effect when you bring sodium or glucose or other dissolved particles across a membrane. It's going to drag water with it. By that osmotic pressure, it's going to be almost instantaneous. So by aldosterone bringing the sodium back in exchange for potassium, the patient's going to expand their fluid volume, their blood volume first, and that's going to increase the blood pressure. Remember, we talked about aldosterone secreting tumors of the adrenal cortex also caused constant hypertension, a very difficult hypertension to cure because it always had the blood volume too high. Also dropped potassium to low levels. Okay? These are the basic fundamental processes going on just to regulate glomerular filtration and flow into those tubules. You can take the fight, flight, sympathetic stimulation, and at moderate levels it doesn't do any harm. The problem is when you get very severe levels of this and you cut off the blood flow to the kidney for too long, we get something called acute tubular necrosis, ATN. The tubules are injured first, and they may die. And if too many of them die, you may lose your kidney. If you're in shock too long, the first organ in your body to go is not going to be the brain. If you're in moderate shock where you're feeding the brain and the heart, but enough to shut off your kidneys may go. And one of the problems we have in patients who arrive in shock from trauma, they may be resuscitated, they may not have brain or heart damage, but we may lose their kidneys in the event. Okay, that's ATN. We also look at this in terms of how much urine is this patient putting out. The patient ATN isn't going to put out any. So we have definitions. We have something called oligouria, meaning a small amount of urine production. This is anything less than 250 cc's a day. Remember, we talk about 1,000 to 1,200 cc's a day as normal. Oligouria is about 250 cc's a day. It usually tells us that we have repairable tubular damage or renal shock. Somebody who's making urine, just small amounts, usually just has to have their blood pressure reestablished, their rehydration, and we sometimes can give certain drugs that will increase the blood flow to the kidneys. These are called diuretics. They work through the bloodstream and they help flush things out and may save the kidney. Anuria, meaning no urine at all, is defined as less than 50 cc's per day. You can put out 50 cc's from just leaking through the glomerulus, and what they call bladder sweat. Just the secretions of the bladder may produce 25 to 50 cc's. Anything less than that is considered no urine at all, and it is a much more serious problem. So that's glomerular filtration. Basically, we've just dumped everything out into the urine. Now we have to get it all back, and that's covered in tubular reabsorption. If we look at the tubules again, we're going to reabsorb different products in different parts of the tubule. The proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, are all going to have places and products that they favor. And there's going to be both active and passive transport. So we're going to both get back our water, and we're going to get back our important solutes, dissolved particles, in a very short period of time. One of the places we want to look first then is at another table, because this amounts to somewhat of a catalog. And I just want you to get an idea of the magnitude of what we're talking about, and then we'll talk about specifics of how they get reabsorbed. Take a look at this table, which it shows us the substances that are filtered right here, and how much, substances that are reabsorbed, which is tubular reabsorption, and substances which are excreted in the urine. You've heard me say the term reabsorption. That's different from absorption in physiology. Absorption is what we take from the outside that gets into the internal milieu. So we absorb proteins, carbohydrates, and lipids through our GI tract into our bloodstream. That's absorption. Here we have squirted it out into another part of the body and are going to reabsorb it. So this is always called reabsorption. Let's look at the substances, and I think it's just astounding when you think of the volumes we're talking about. Remember, we don't have much more than a gallon of blood volume in our system. If you look at the water, we filter 180 liters a day. It's an enormous volume. Just think of carrying 180 quart bottles of liquid. We will reabsorb in that 24 hours all but 1 or 2 liters. Very, very efficient mechanism, obviously. And if we don't get this much in, so this ends up being how much we tell everybody they ought to be drinking or eating with their food. Because that's the obligatory water loss that we're going to get rid of, and we need to make that up every single day. If we stopped drinking, we would dehydrate rather rapidly. The kidney would try to control that. The kidney would try to reabsorb even more, but that can only last for so long. There is an obligatory loss of water as we send out certain chemicals. Look at the proteins. We allow to get rid of 2 grams, really not very much, but we get almost all back except for 1/10 of a gram. Sodium ions, again, sodium is very effectively reabsorbed. We filter that much. We reabsorb 575. We only lose 4 grams. When you are on a normal diet, a person eating an unrestricted diet usually takes in about 4 grams of sodium. When your doctor tells you you're in heart failure or you have other problems where you have to restrict sodium, high blood pressure, usually a moderate diet would be a 2-gram sodium diet. And a 1-gram sodium diet would be for really extreme deprivation in order to get your blood pressure down. So again, this fits right in with what we know we eat on a normal basis. Chloride ion we haven't talked too much about, but again, it's very effectively reabsorbed. And bicarbonate, which is our buffer system that helps us maintain a stable pH, we absorb most of it. We only get rid of a tiny fraction of what we are filtering. Finally, glucose, and this is the big one, we should not excrete any of it. We excrete in the glomerular filtration, we filter 162 grams. That's a lot of sugar. There's 4 calories per gram of sugar, so that's a fair amount of sugar, but we get it all back. And any loss of sugar into the urine is abnormal. Now, when a diabetic, here we get back to diabetes, when the diabetic is producing blood levels instead of 100 milligrams of sugar, 1,200 milligrams of sugar, the tubules can't handle this. So the filtrate's going to contain sugar, but so is what finally goes into the bladder. The tubules cannot reabsorb that much sugar. And there's an osmotic load. It's going to have an obligatory loss of a lot of fluid that can't be taken back across the tubules. The patient's going to have diabetes mellitus, copious sweet urine, and they're going to become dehydrated. And then if we want to remember all our feedback loops, the brain's going to sense with its osmotic sensors that we are too hyperosmotic because we've lost too much fluid. And it's going to do a couple of things. It's going to tell us in our brain that we are dry. It's going to signal the saliva to decrease its output so our mouth feels dry. It's kind of a signal to trick us into drinking more water. and our mouth will go dry from both the osmosis and the lack of saliva, and we will naturally drink more to reestablish that. And that's what the polyphagia and polydipsia are about in diabetes. Finishing up now, the urea is almost all excreted because that's a waste product. We want to get rid of it, and it's not reabsorbed very well. Just a bit of it comes back in, and we measure urea as a measure of kidney function. Potassium ion is one that we get rid of a little bit during the day, and uric acid is one we haven't talked about, and creatinine is a breakdown product of muscle metabolism. And the creatinine actually all goes out in the urine. It's kind of toxic to keep around. And we measure both urea and creatinine in the serum to measure kidney function. As isolated measures, the creatinine is more consistent. Urea can go up and down depending on other things in your diet. Creatinine tends to stay very stable. I won't go into that until we get to how we measure kidney function. So as we move along the tubules, now we will see different things going on in different sections of the tubules in the way of both active and passive reabsorption at different places. The distal convoluted tubules reabsorb ions and micro-regulates. So what happens mostly is the big guys, the sodium ions and the glucose, are handled first in the proximal convoluted tubule and the descending loop of Henle. Here. So we're going to do most of the work right here. And then on the way back up, we're going to micro-regulate on this side, because at that point, the filtrate that's in those tubules is already getting closer to what it should be, to what we want the internal milieu to be. Now, there are final adjustments that are made. That aldosterone also can go ahead and get better regulation of what's happening in the distal tubule. If you look at and this now is a cartoon of all the different kind of cells, when we get all the way over to this point, the final collecting tubes, we have these intercalated cells or intercalated cells, which are between the principal cells. The principal cells are able to facilitate the uptake of the final products that they need to get back and regulate the amount of water relative to what we're putting out in the solution. So it gets one last chance in this collecting system to make a final adjustment. Now, we have something called obligatory water loss. This is the passive loss that is regulated by osmotic pressures. And this occurs mostly in the proximal convoluted tubule and the descending loop of Henle, and a little bit in the distal convoluted tubule. There's something called facultative water reabsorption, and it's aided by antidiuretic hormone, which we mentioned comes down from the brain, as well as aldosterone from the adrenal cortex, and that occurs in the last part of the distal convoluted tubule and the collecting ducts, and that gives us that last squeeze of the sponge to get the urine back inside. Remember that ADH was the one that came into play when you drank a lot of alcohol. It was cut off, so it was an antidiuretic hormone, meaning it wants you to absorb the water, and it was blocked by alcohol, so you lose a lot of water in the urine. You tend to get dehydrated when you've taken in too much alcohol. That's how that comes back to plague us. Finally, we get down to the secretion part of this system, and that occurs mostly in the tubules to get rid of unwanted materials. For example, there are hydrogen ions. The pH balance in the body is, as we realize now, very, very delicate. The hydrogen ions are the ones that are on the acidic side of things that create acid. And when the pH is too acidic, we have an active pump to get rid of those hydrogen ions and put them out in the urine. So we acidify our urine actively by pumping it out, and most of the time when you put a dipstick in the urine, you'll see it's on the acid side of neutral. We can also increase our bicarbonate ions, in that area so that we can maintain the internal milieu and we can increase the reabsorption of that bicarbonate or not, or decrease it depending on what the body pH is. We also can handle the potassium ions, very, very important. Remember that only minor fluctuations in serum potassium had a profound effect upon both nerve conduction and muscle conduction. Such a serious effect that, in fact, if you let it get too high, let's say double from 5 to 4.5 or 5 to 9 milliequivalents in the blood, you can actually stop the heart. And a rapid infusion of potassium will stop the heart. It's lethal. So we have to keep a very careful eye on the potassium, and the kidneys do that for us. It's very, very active. Potassium and sodium tend to go in different directions. So when we're absorbing the sodium, we secrete the potassium, get it out in the urine. And I talked to you about how in renal failure, the patient who was getting their potassium going up, when we saw that patient in the emergency room, one of the methods was to give glucose and insulin because there was an obligatory taking of potassium back into the cells of the body when insulin drives sugar into those cells. Remember, that was the emergency treatment of renal failure where the potassium was going up. That works for a while, but then we have to do something else. And in patients who are undergoing dialysis, who have no kidney function, whether the kidneys have been removed or they're just not working, those patients have their potassium problem being their most serious problem. So one of the things we do for them is we have them, first of all, on a very low protein diet, because the protein breaks down into toxic material that can get into our blood and make us sicker faster. But we also have them monitor their potassium very carefully. They'll avoid canned juices, bananas, things that the rest of us take to increase our potassium for our well-being. Those patients don't want to have so much potassium in their blood. Now, we talked about peritoneal dialysis. We talked about how we get some of this material off. I'm sorry, we talked about hemodialysis in the last lecture. I want to mention that there's another way that we used to use, just out of historical interest, before we had these excellent machines that could dialyze the patient using blood quickly and very safely. We used another membrane, and it was called our peritoneal cavity. Remember that the peritoneum is covered on all its sides by parietal, the cavity is covered on all its sides by parietal peritoneum, and all across the organs with visceral peritoneum. Those are osmotic membranes. And what's running through them but masses and masses, miles of capillaries. So if we took a fluid and we put it in the abdominal cavity and we made it just the same concentrations of everything we wanted in the blood, osmosis would occur across the peritoneum and dialyze the patient for us. And we did that. That was the first way we dialyzed patients. We'd actually poke a trocar, sharp metal instrument, through a safe place in their abdomen, feed a catheter in, and we'd fill them up with half a gallon of the fluid we'd want. We'd slosh that, literally slosh it around a little bit, and then turn them on their side and let it run out. Interestingly, a lot of that was absorbed just the way it is through the rectum, and we'd only get some of it back. And then we would measure all the chemistries, and we'd do it again until we got the patient dialyzed to where we wanted them. Problem with this is it was a stab wound, certainly a surgical stab wound, but we were intruding, and these patients tended at some point to get infections. The other thing that happened is the peritoneal cavity doesn't like that any more than it likes us handling the organs, and eventually adhesions would form, little scars between the intestines, creating pockets that are walled off from the rest of the abdomen, and we got less and less effective with time. So we ran out of time that we could use peritoneal dialysis, and that was the stimulus that made us find something else, which was hemodialysis. We went directly to the blood cells and an artificial membrane, and that's still the standby today. There are some other things we should look at here. The word diuretic is one that's very, very popular, and we hear about these drugs a lot. A diuretic is something that causes a diuresis, which is an outflowing of larger than normal volumes of urine. We do this, I would say the primary use of a diuretic is to control blood pressure. Whatever the cause of the blood pressure may be, we have a tank creating a head of pressure, our vascular system. If we could shrink the volume inside that tank, we could let the pressure come down. The cause of the pressure is one thing, usually atherosclerosis, but it may be other things. But the results of the high blood pressure is more damage to the vessels, more work for the heart, more injury, let's say, in the brain and the coronaries and the peripheral vessels. We want to get that blood pressure down no matter how we have to do it. So the first line of defense is something called osmotic diuretics. We used to give patients drugs that were heavily osmotic quickly to just run the urine off them. That doesn't last too long. You can give somebody a huge load of sugar, make them diabetic for a few hours. Sugar will go out in the urine and you'll have an osmotic diuretic. The next thing we used, people can use caffeine because that decreases the amount of sodium reabsorbed. It blocks the chemistry, and therefore the sodium goes out in the urine, and so does the blood volume because the water follows it out in the urine. So caffeine, we've all experienced the effects of too much caffeine, although we're not using it as a diuretic. Alcohol works that way, but one of the best drugs we found is called Lasix or furosemide, and that works in the loop of Henle. It's called a loop diuretic. It's a chemical diuretic that's extremely potent. If you have a patient that really needs to get rid of that water, that may be seriously ill, you can give them Lasix in certain doses that will literally take off liters in a day, gallons if necessary. In fact, it has to be used carefully because you could drop their pressure too low. Lasix also works by increasing blood flow to the kidney. While it's acting as a loop diuretic, blood flow to the kidney improves. So when we have patients that have borderline renal function and may have been in shock, one of the things we do is we give them a whiff of Lasix, just a little bit, to increase that flow through the afferent arteriole and maybe try to restore blood flow to the kidney and therefore filtration and therefore get everything going again. It's very effective. Again, like all our drugs that are so effective, it requires great care in the use of it because using too much of it can be very, very dangerous. And then finally, we ought to look at how we analyze the blood and the blood products. We do a urinalysis. In the urinalysis, we looked for both abnormal and normal components. Normal urine should be clear, should not be cloudy, should have a pH within a certain range. It should be concentrated, more concentrated than the blood, because we're trying to save water and get rid of some of the products. We also should not have any red cells, any white cells, no protein in there because we want to keep those inside, and all of those indicate the presence of a problem. We have to figure out what that problem is, but they indicate a problem that requires further looking at. So a simple urinalysis can tell us whether there's glucose in there, whether the patient is acting like a diabetic. Simple test done in literally minutes. We can look at it under the microscope, look for bacteria, which shouldn't be there. Something called a cast, which is a piece of statuary that has been lining the inside of the tubules that gets flushed out if we have uric acid or oxalic acid, other things that form stones. They can tell us something's wrong inside the tubule. And then we can do tests by measuring the BUN in the blood, the urea nitrogen, blood urea nitrogen, which shouldn't be too high because that means we're not getting it out in the urine, or the creatinine. And we can also do a much more sensitive test called a clearance test. The clearance is the amount of product that can be taken out of that filtrate and brought back into the body. So for example, we should be able to clear all the glucose back into the body that we put into the blood. Well, creatinine happens to be a very sensitive one, so we do creatinine clearance. The body doesn't like creatinine, and we can tell how much creatinine in a given dose should be in the blood and how much should be in the urinary output, and we measure those over a period of time, gives us a very accurate measure of renal function. And this in turn can lead us back to what's going on with the whole physiology and the pathophysiology of the kidneys. That brings us to the end of the excretory system. Next time we'll pick up and look at the male and then the female reproductive systems.